and get, and then I can go ahead then to and share my screen. All right, so can everybody see the slides? Are we good?
Yep.
Yep.
Awesome. Okay, great. And then perfect. Alrighty. So I'm really glad to be able to come back and share with folks and get to kind of introduce myself a little bit more. I know I did sort of a shorter introduction yesterday. I've started doing presentations now where I do this map so that I don't forget to name things, as well as to kind of give a bit more background to who I am in terms of positionality and where I'm coming from as well. So my name is Kate Luxion. I am currently a PhD candidate at University College London. As you can see, that kind of weaves quite a web. I was part of the 2016 cohort for the LGBT certificate in mostly reproductive health related things in terms of my capstone and such. And at the same time, I was working on getting my MPH at George Washington as well. So I kind of came to the program doing those two at the same time. Shortly prior to that, I was doing a graduate certificate in gender and women's studies, where I founded the Journal of Reproductive Justice. And that's mostly parent facing, making materials for LGBT parents and queer folk to sort of help them self-advocate. And that's a lot of the research that I'm doing now. I also teach social sciences, social psychologist and public health researcher in terms of my official labels, but I'm doing a multi-site hospital study right now, sort of expanding on some of the data that we don't have in terms of pregnancy and birth outcomes for queer parents. To give everyone an idea of what we're going to be doing today, it's looking at really an overview of what reproductive justice is. This is easily a full sort of semester plus worth of information for at least one course. So it is going to be more or less an overview than necessarily as deep and nitty gritty as I'd like, but hopefully it starts the conversation and kind of gets people interested in different areas that you might not have been interested in before, or gives you a bit more information that you may not have had previously. There will be obviously slides that Steve will be able to share with folks, as well as this is structured based off a chapter that I wrote for Wiley Blackwell. So you'll be able to have a full list of references as well as something to read as available to you as well. And if you're not able to access it through the library, just let me know and I can get you a copy of it also. In terms of what reproductive justice even means, my go-to definition is from an organization that's founded and run by women of color, which is Sister Song in the US. And they focus on the idea of not just having children, starting a family and family structures, but also then reproductive autonomy, meaning that you can choose not to have children, as well as then branching out beyond just the family constellation to include the communities in which families are being formed. And I'll repeat it a couple of times, but really families is a term that's used not just to be in terms of like two adults and children or one adult and children, but really like chosen families and the various structures that we see within the queer community in terms of what it means to have or be part of that kind of support system. Along with starting kind of with the positionality bit at the beginning, in terms of where I'm coming from and where I'm positioned, I also like to start with the limitations so that folks know the caveats before we get into the information. So most of the research that we have available suffers from a lot of the common limitations that we see in research, which are the whiteness of samples, the level of social capital that people usually have available to them, be it income level, or education level. And so a lot of what we're going to be talking about requires there to be some barriers sort of down in addition to then the other barriers that are there. So being able to have the financial means available to, say, do transnational or international surrogacy or adoption. And so that's something that we need to keep in mind, as well as there being fairly limited data in regards to much of this is going to be data from the context of where it's safe to get data from, because we'll talk about legal constraints in a bit, but that shapes a lot of the discussion as well. Language is another big thing that shapes the process. So when it comes to family health and reproductive medicine, it's already structured in a very cis heteronormative way in terms of making assumptions about the gender of the people who are coming in to get reproductive health services, mostly framed with the assumption of it being married, cisgender, white heterosexual women who are receiving the care. And even in instances where things try to be a bit more inclusive, it makes it very difficult because of most of the issues being at a system level, to have everything kind of ironed out and smoothed away. So we have to think about everything from the intake forms to the way that folks who are at the intake desk are working just as much as folks who are actually administering or kind of facilitating care throughout the process. There is a really kind of intrinsic link between language and outcomes that we see in the minority stress model. This is going to look slightly different than potentially the one that you saw in the, I'm assuming you have read the Frost and Meyer paper from 2012. So this is an adaptation of that model incorporating intersectionality because of that being extremely important. And we can look at minority stress and we can see that connection between the spaces and the systems that people are moving through as more so the cause of kind of issues, as well as where we can sort of make sure that we're addressing concerns to do a bit more capacity building in regards to supporting patients, as well as enabling them to have access to the resources that they need to really have the resilience side of things as well. And I like to use tangible examples for things. I did mention a bit earlier that I do teach, and so I wanted to make this a bit more interactive as well. And so this is the model of the research that I'm doing right now. And we can see that with the structural stressors or the general stressors that everybody faces, that minority stress, we remember, is that additional proximal and distal or close or slightly further away events that are happening within life that are causing that additional layer of stress. In this case, we can see some of the examples as the stigma that people feel, the safe need that they feel in terms of how out are they to family and friends, whether or not there's other experiences that they've had, things like being homeless, being within the child welfare system, the chronic strains of stress, as well as everyday discrimination, and whether or not those have a prevalence within their lives and can have an impact. And then we can look to as well to see then the resilient side of stuff in terms of more of the internal bits of resilience. So what are the coping behaviors that are happening? What's that feeling in terms of social support side of stuff, as well as then the connection to the community, which is a really interesting topic when it comes to queer families in particular. So we'll dig into that a little bit more later. And we know within the minority stress model that with these various resources and these various kind of dimensions of things that are available to people, that it's about how they really interplay with each other in terms of there being this outcome, this expectation of either some positive or negative health outcomes. And I really want to emphasize that it can be both. There are some elements of family life that actually do have protective qualities to them as well. So a lot of what we've talked about so far, the disparities, and this is a topic that's really intriguing to me because there's a lot of myths about the negatives around queer families or what it would mean to be a gay or bi or lesbian parent, and what benefits it can bring is really helps us shift that narrative as well. So we can see in the model here that this is the parent's health, and it's embodied in allostatic load, which is the concept of seeing really a biopsychosocial model. So taking biosystems, taking the psychological strain of things, so taking the social context of where we're living, and being able to see then how that intersectional minority stress model plays out. And then what reproductive justice does, and having that lens to things, is it puts one more layer in place. This particular image is directly related to the context of pregnancy and birth outcome, but you can see this as well in terms of outcome during adolescence and in later life as well. But it's having that sort of intergenerational side of things as well, seeing how there is that benefit or how there is that impact from one generation to the next. So we have to kind of think about that in terms of how things are. So knowing then the foundation of that minority stress side of things, knowing that there's some language constraints, I wanted to talk a bit in terms of legal constraints that happen for LGBT folks that are either have families or are trying to start them. And so this is the list of countries where it's currently illegal to be homosexual. It can be variable depending upon sex, in terms of, in some countries, it's only illegal to be homosexual if you're male. Some, it's for both folks who are male and female. You have some contexts like Iran, for example, where they actually have people transition as a form of treatment for homosexuality, which is a whole other discussion in and of itself. There's also the issue that we run into as well, and we'll talk about abortion slightly in a little bit, but that there's unfortunately in these contexts things like quote unquote curative rape that will happen, where folks are raped by either close family friends or family members in an attempt to show them that they're not actually queer. So there can be that then cascades into access to abortion, access to additional care, access to really just safety and safe spaces. So moving sort of beyond kind of the US side of stuff, it's important to note the international scope of it, because whenever there is a Republican president that's sworn in, there is an executive order that's signed that is a global gag order that actually restricts the ability to speak about abortion on a global scale and causes folks to potentially lose access to funding at the clinical level in other countries. So if we think about the queer folk who are in these contexts that are having to experience things along the lines of curative rape, etc., they then are losing access to being able to have abortion and other care like that through then the direct sort of political consequences of the states. So it's all very complicated and very interwoven in terms of how the legality side of things work. There will be, when we get to the case studies, a PDF of the slides, so you'll be able to reference that, because not all of the case studies will be situated in the US. But this is a quick overview of the expectations, first in the Europe, kind of UK area, of who can access assisted reproductive medicine. So you'll notice in some cases it's not available at all. In other cases, there's the caveat that it's only possible if it's same-sex partners who are women. There's an exclusion of single men, an exclusion of folks who are trans or intersex. So it can be very specific in terms of who's able to access it. So another caveat in that, just because something is available, it's not available to everyone. So being able to understand what that might mean. And then we can see here too, in terms of, then this is the rest of the other continental areas in the world. So if we look at kind of the variability of being able to access different things, it's not really a given either that you can access assisted reproductive technologies in the States, depending upon your sexual orientation as well as your gender ID, because it kind of depends on insurance. And that's another layer that tends to complicate access and what is available to people. Since we're talking about different methods and modes of starting families, it's important to note that it can influence what it's like for surrogates as well. And for both surrogates and gestational parents, that automatic co-parent recognition has an impact to where if the gestational parent were to end up being a casualty or have a complication, that very quickly means that their partner would not be able to not only help to make medical decisions for them throughout the process, but would not be listed as the parent to their child as well. So it's making sure to sort of note as well whether or not there is automatic co-parent recognition, and instances on us when you get into like Canada and the US, there are some differences on a state-by-state basis. And again, depending on surrogacy versus assisted reproduction. For adoption as well, that's another area where the legal side of things is very kind of interesting and complicated. There's in the US, for example, you can do a second parent adoption, or sometimes called a step parent adoption, if you go through the process of having a kid and then you're either blending two marriages together, or you have to where you've given birth and then you're wanting your co-parent to be on the birth certificate with them. On paper, legally, you're able to access that. However, it's dependent upon going through the legal system, which means that there are states like Arkansas and Georgia where you can be in front of a judge and a judge can just say no. And the reasoning there is kind of that right to refuse treatment that we were talking about a bit yesterday, is just like that's enough. And from the same standpoint, when you get into adoption from the standpoint of looking at joint adoption, you run into similar issues in terms of, again, you can go through, have made it through the hoops in terms of finding an agency that will take you on, going through any sort of psychological screenings that are required, going through the home visits, and again, get up to a judge and be told no. And at any point along that process, be told no, and have it be dependent specifically on who you end up being put in front of. There's also some differences in terms of cultural context that are important to take into consideration, because you'll notice here that just joint adoption is listed in Brazil, but there is actually a local tradition to where then they refer to them as Brazilian adoptions in context, to where it's actually a bit more common for families to blend and have one set of biological parents give permission to another set of parents to sort of adopt their kid, and sort of switch families and make families in different ways. So just legal access, like I don't guess is the caveat with that, is legal access doesn't necessarily mean access, but it also doesn't necessarily mean that there's not access. There's not different ways of making families too. So making sure to know a bit more about the context there. So family making, as we can kind of see through all of the legal side of stuff, the jargon side of stuff, there's a lot of different ways that it can be that families are created. So again, you can have the blending of two different families that are coming together, either from previous cis heterosexual relationships or from previous queer relationships that are requiring access to adoption services, access to making sure that they have legal parenthood rights so that they can make sure their children have access to school where both parents can be involved, where both parents can be involved in medical decisions, and making sure that they are able to have safe spaces to exist as families. And so we are going to talk a bit more in particular about those kind of services that then need to be available along the way. In terms of family planning, it's both from the concept of being able to retain fertility and start a family, as well as then thinking about the reproductive health side of things that goes along with that. So we have spoken some in some of the other sessions in terms of expanding the language around menstruation, making sure that there's more availability and more of a trans and gender expansive inclusive policy around menstruation. So making sure that the language and the staff and everything are in place to allow there to be patient guided services that are there, as well as to think about different instances. So for example, PCOS is a common condition, and actually has some diagnose, like the criterion to diagnose it. If you haven't had a chance to look at it in detail yet, I would recommend that, because you can pretty much in some ways look for people who are sort of queer presenting, and that can sometimes be used as diagnostic criteria. And that involves some cessation of menstruation. And that's part of where some of those endometrial cancer risks come from, and some of the other issues that could potentially contribute to some of the disparities, which then we can kind of track back then if we're making assumptions that a lack of menstruation is what somebody wants, rather than kind of a complete education of what that might mean for them. We need to make sure that we're taking that same approach to realize menstruation is an automatic dysphoria for folks who don't present as femme as well. There's also, and I wish there was research on this, there's not much more than anecdotal. There is also the consideration that has to be made for, there are some trans women who report having cramping and symptoms that are similar to kind of PMS and things that we associate with menstruation well on HRT, but I'm not sure that there's really spaces that talk about that much. And because there's not necessarily that ability to sort of have care for them because of that, so having that consideration. Cervical health and some of the things that have been happening to task shift, to use a public health term, to sort of help with some privacy issues and some access issues, are at-home cervical screenings, and having those become more available so that folks who don't feel comfortable going in clinic can more actively have a hand in preventing cervical cancer for themselves, as well as encouraging others to have more common screenings. Other screenings as well that are important are things along the lines of chlamydia and other STIs, as we've spoken about in other contexts as well, because those can impact fertility. And then when we think about contraception and abortion, remembering that labels are really good from the standpoint of raising awareness, but at the same time, when we are talking with folks, that it's important to remind them that somebody can ID as a lesbian, but then also as you get to talking to them, say that they have a regular partner who has a penis, and then they could conceive but don't want to, sort of deal. So you have to sort of speak with them in terms of what they want out of their care. So you can't make automatic assumptions that contraception is or isn't needed, as well as the sort of off the script use in some cases from the standpoint of, again, returning to the PCOS thing. Some folks opt for taking a hormonal birth control pill to help with the dysmenorrhea side of things. So thinking about that a bit more. So all of these things really do fold into this idea of talking about the retention of fertility, which is something that builds off of this, that there's this long history with trans medicalization of things, of actually requiring the fertility of people to be stripped away in order to then transition legally. So we have to think about how all of these things are linked together as well. So folks might not know they have another option. I was at a conference for trans pregnancy in the UK here, and there was a presentation that spent the entire time critiquing the fact that one of the key citations, and I'm happy to share the citation that was spoken about, was that was being used to determine that hysterectomies were mandatory, had a low enough sample size that in any other context it would be statistically questionable, that so many sweeping recommendations were being made of having hysterectomies happen because of the hardening of the uterus, that because there's not any other data, it just became kind of the go-to. So it's having more trans-led research and having more discussion around these things, because of it moving towards self-determination allows there to be a bit more of a critical lens used in terms of what some of the things we recommend, if they're really necessary, and when it can be more sort of guided by the patient in terms of the process and the timeline, because it doesn't deny them the legal transition that they need, or the elements of the kind of medical bits that help them to socially transition. Other sort of conception related family planning bits. So there's this idea that to have a family as a queer family, that you have to have some sort of medical interjection in some way. There is, and I wish there was more literature on this, and Kat will probably know sources to go to, but there's one really good anthropological paper on it. But there's sperm rending that would happen prior to the medicalization of assisted reproductive technology, to where you would have a network of lesbian families and gay families who would coordinate with each other, who would want to donate sperm, who would want to be anonymous, who wouldn't want to be anonymous, who would want somebody who was a known donor, not known donor, and they would coordinate having folks link up with each other to be able to start families. So completely out of clinic, having this process happen. In the 80s, with the advent of it being a bit more supported within the medical institution, there is a shift in terms of moving folks more into that clinical side of things. And with that move, there's more and more recommendations then in terms of asking folks, if you're choosing to go with assisted reproductive technologies, if you're choosing to go this route, then you should also be doing this in tandem with legal agreements and all of these other things. So it's meant to be more inclusive, but at the same time, it's requiring people to go through more and more interactions to where you have to find people who are supportive along the way. That being said, there's some really cool and interesting things that are happening in that way. There is one researcher at the Imperial College London here who's specializing in uterine transplants. And so there have been viable births that have been happening out of transplanted uteruses. And so the discussion in terms of what that might mean for trans women who want to carry. I know that there's some talk about being able to synthesize gametes using bone marrow, in terms of then lesbian couples being able to both contribute to the process of fertilization. And so it's really interesting, as well as then more so established things that are already sort of approved clinically, are the ability to where the implantation and fertilization can happen in one partner, and then it can be moved to the other partner for the gestational carrying side of things, so that both partners can be involved in some way. There are partners who choose to both can be pregnant at the same time, so they can go through the process of in vitro fertilization and then both have an embryo implanted. And then it can be to where they sort of set everything up beforehand and kind of know we're going to have about 3 kids. We end up having 4 or 5 embryos, and then sort of have a very succinct plan going forward, depending on what's available to them. So, because the last 2 terms on the list, there's some insurance barriers that unfortunately we have to talk about, from the standpoint of biological infertility is now sort of being put at odds with social infertility, from the standpoint of the way that insurance protocols are written up now. Even if you have folks who have done that IUI, or that attempted inseminating at home, for a couple times, if they are a lesbian couple on paper, insurance requires them to go through more cycles or more rounds in clinic to be able to then have IVF approved, whereas a cis hetero couple can go into the clinic and kind of just sit down and say, hey, we've been trying for X number of months and don't have as many hoops to go through. So the way in which information or evidence is valued is very skewed in terms of not being in favor of queer families. And so they have to sort of prove then biological infertility in the context of the clinic in the way that cis het families do not have to. So there is an additional level of stress or strain in that regard as well. And then this is where, to me, the exciting bit happens, only because there's absolutely no data or very little at that. So when we get into pregnancy, most of the research talks about the discriminatory experiences that queer folk face in the context of getting care during pregnancy, during birth, during postpartum recovery. And there's not really a connection that's made then to pregnancy and birth outcomes specifically. We do know from research in terms of racial minority parents that there is a link between low birth weight infants and kind of early preterm births. When you're looking at the impact of discrimination on pregnancy, one of the key developmental hormones in utero is cortisol. So if you've dysregulated cortisol because of that impact, then it makes sense, both kind of, I feel, common sense and biologically, that there would then be something that kind of skews things. What's not discussed a lot, though, is that if you're born preterm, you're more inclined to be preterm, in terms of like your infant is more inclined to be preterm when you have children. And so you get these intergenerational issues that not only do you have the next generation that's already more inclined to have these complications, but then, especially from the standpoint of racial discrimination, they're more inclined to face additional discrimination based off of race, and then it kind of compounds the issues that are there. So the model I showed earlier, I will hopefully have a bit more data then on what it means in terms of the impacts of discrimination on pregnancy and childbirth in a couple of years once I finish writing up my dissertation. What I can tell you from the capstone project that I did when I was at George Washington was that, and in this program specifically, is that there does seem to be a significantly higher rate of miscarriages for lesbians, and there is a higher likelihood of complications like macrosomia, which is larger infants, for bisexual parents. There's some of that that's mirrored in an exploratory study that's been done recently by Janawala and company. And so there's teeny bits there that sort of mirror what we're seeing in terms of racial discrimination. So seeing how that plays out in the queer community, specifically using an intersectional lens, will hopefully help to fill that kind of need for more actionable data. Pregnancy doesn't happen just in the context of the person giving birth being one of the intended parents, though. So there's also surrogacy. And the options that are there would be to have somebody who is both, if it's a gay couple who are providing sperm as the gamete, that then the surrogate is providing both the egg or the ovum for fertilization as well as carrying to gestation. That would be considered the traditional or partial surrogacy. If you have somebody who's being the surrogate and then you have two outside sources of the genetic material, then that's the full surrogacy side of stuff. Currently, the only place that you can have a surrogate as a gay couple or as a queer couple, because it includes lesbian couples as well as trans couples and other couples under the umbrella, and pay them, is the US. There are other countries that do allow surrogacy to happen, but it can only be altruistic surrogacy. So you have to find somebody who's willing to serve as the surrogate without being paid. Periodically, there are loopholes in terms of they're not getting paid, but you can gift them $35,000 for 9 months kind of deal. So there's weird bits around that. There are some people who choose to then go the international route of things in regards to making the decision to pass as a single person working with a surrogate so that they can get around the laws that restrict access to couples who are not heterosexual, and then decide to deal with the legal loopholes or like legal barriers that they have to jump through after the infant is born. There is a lot of research that talks too about clinicians who choose to work with families sort of in other countries. They purposely situate themselves near borders to help sort of deal with and address some of the laws around both the pregnancy side of things and the surrogacy side of things to help make it more accessible for people. So going back to that, the discussion of the legal boundaries and barriers and what that means for folks. And so there's not much that's available really beyond the US context. And even then, that's where you get into situations where you have to be very particular about making sure all of the paperwork and such is in place, so that you're not in a state where the surrogate can go ahead and choose not to then have the infant kind of be handed over, as well as then it's not all bad. And the standpoint of, there's also then what will happen sometimes is there will be surrogates that, regardless of no prior relation to the couple who are having the kid, or the individual who's having the kid, who stays around in their life as a special aunt, or has this extra story that they have to stay connected to the family. And sometimes you'll have two, to where it ends up being a family member that serves as the surrogate as well. So there's lots of different ways that that plays out. Adoption. So there's the two different types of adoption that were brought up on the legal table that we're looking at earlier. And so that can be folks who are adopting just sort of as single parents, as co-parents, adopting kids from prior relationships. There's lots of different ways that this plays out in terms of the foster care system and other things. And again, those same kind of issues that you might run into there. But at the same time, there are things like a parenting magazine and other local organizations that help parents to connect with organizations like this, help different places to work together. There's the Family Equality Council, which is a nonprofit organization in the US that does a lot of really good work in terms of lobbying around access for parents and stuff like that, to make sure that there's improved access for second parents or co-parents who have to adopt after their kiddos are born or adopted, as well as then online spaces. So more anecdotally seeing people who have asked questions in terms of trying to navigate legal systems by knowing if people have any info about particular judges in their county, so that they can work with their adoption lawyers to try to make sure they're in the right kind of courts to sort of reduce the number of barriers that they face there too. And then kinship is sort of one of the other things in terms that families don't always have to be legal families on paper too. It can cause some issues or some concerns in terms of who's allowed to visit, who has power of attorney with medical decisions later in life. But it's important to note that, again, family and family formation and kind of where families come together and are made can be folks who don't really get to be into each other's lives until much later down the road and are part of a web of more of a chosen family side of stuff, which is, I think, pretty common in terms of the narratives of most queer folks that I have spoken to. So even if they do have biological families, they also have chosen families as well. But it's interesting from the standpoint too, is that as we see more folks kind of aging into spaces that are not queer inclusive, so care homes and other stuff like that, that there needs to be a shift. If somebody hasn't centered on a topic yet, there needs to be a shift in making sure that there are procedures in place to welcome these kind of family structures, so that you can have folks that have more of a support system, that don't lose it just based off of age and how families are or are not recognized legally, because there are benefits in terms of having those connections there and being able to have connections beyond the assumed or presumed kind of biological connections that are happening. So as well as then expanding the narrative beyond the idea of a two-parent household family. So expanding from the standpoint of polyamorous families, open sort of relationship families, as well as kind of single parent homes as well. And then for the note about miscarriage and the higher likelihood of that, one of the reasons that this is something that really needs to be addressed is because there's sort of a doubling or multiple layer of loss that happens from the standpoint of there's not really a space for queer parents to grieve. Most of the framing is built around, again, cishet parents, as well as if we think about, for some folks, if they just have enough for a couple of cycles of insemination from one particular sperm donor, and that's something that they've spent the last 10 years saving up on, and they experience a loss. Like there's multiple things that are being lost there, as well as the support systems that they might be signposted to aren't structured to be supportive of diverse families. And so keeping that in mind in terms of what sort of systems are available there as well. And then lactation, which is another thing that's really interesting and intriguing, and allows you to take the narrative and kind of spin it on its head from the standpoint of, if you look outside of Western contexts, so currently it's starting to become a little bit more widely accepted in terms of the use of the term chest feeding. So for folks who are not femme-identified, who are choosing to lactate and then feed at the chest, that there's options and things that are available to them, from supplementation to support that is actually competent. And then if we go back even further, kind of step beyond the Western context, there are cultures that are still in existence. So the Aka tribe or Aka tribe in Africa, there is a sharing of responsibilities in the home to where the mother feeds during the day and the father dry nurses at night for comfort. And that's how they split responsibilities and stuff. And so you get these very highly sexualized Western constructs of like very hyper masculine sort of treatment of lactation and breasts in the West. And then if we look at other contexts, that there's a lot of the arguments that are used in the West of like, well, that's not like, men don't have nipples for any purpose, or all of this other stuff. Every human being is actually born with the same mammary glands, and the development of those glands is dependent upon particular growth hormones that they're exposed to. So there is case studies that are available in terms of a trans woman who induced lactation, so went through the process of the Goldberg, I think it's Goldman-Newberg protocol in terms of being able to induce lactation, and she was making enough milk to help for the first 6 weeks and then ended up supplementing afterwards. So other ways in which people then can interact with human milk and making sure that nutritional needs are taken care of, as well as an important thing to note for care providers beyond just folks who are in childbirth or birthing spaces and stuff, is after 16 weeks. So if anybody experiences a loss at 16 weeks or after, your body actually still goes through the process of making milk, which means you have folks who are dealing with that as well as the loss that they're sort of processing. So for some people, they choose to go and allow their body to go through the paces and then donate the milk and continue to do that as a process of grieving. And then other folks that just need to then have their care team aware so that they can have assistance in making sure that they stop milk production so that they don't have mastitis or other inflammation issues that can pop up and infections that can take place in that regard. So that covers most of the kind of leading up to parenting side of stuff from the reproductive sort of side of stuff. But then for the parenting side of it too, and I'm gonna switch over to case studies shortly here, that there's a lot of, again, negative narratives around, well, to have successful kids, you have to have this very specific, right? It's a mother, father, 2.5 children, and white picket fence. I think that American dream sort of narrative is still extremely pervasive. And that's where you get a lot of pushback from the person who's supposed to be signing off on the home visit, or who's supposed to be signing off in court and saying, yes, this is okay, you should do that. But when you actually look at the research and you actually look at the kids who are in queer-headed households, they typically have either the same or better adjustment levels as the kids who are in cis-het households who are considered to be at lower risk. They usually have a better ability to navigate really stigmatized systems and stuff that would otherwise be judging their family, because of the benefit of being within a queer household, because they are being able to have those skills as they're growing up. So there's a bit more of an emotional intelligence side of stuff there as well. And then it's also because there tends to be sort of more even distribution of what the parents are doing within the household. And it seems to be too that there tends to be better relationship satisfaction in those households as well. So it's interesting from the standpoint of a lot of the reasons that pop up in mainstream media, and even in some, you can find it in academic articles, but they're mostly ones that are coming out of, for the most part, like evangelical Christian colleges and stuff that are still claiming these particular narratives, actually aren't prevalent when you're going into the full body of research that's there. And it's from the same standpoint in terms of what that means for parent health also. So when we talk about things like being wary of postpartum depression and other things, that there is a protective side to being a queer parent from the standpoint of lesbian parents in a research cohort by Ross, who's a researcher out of Toronto in Canada. When she was looking over stuff, she found that there was a protective element in terms of less likely that lesbian parents would experience the same level of negative mental health outcomes when compared to the cis heterosexual couples that were in the study. And it seemed like it was because of those relationship dynamics, because of the level of communication that was happening within those relationships, as well as the level of planning that went into starting a family and having that sort of take place. And so it also shows up as being beneficial, not just to the gestational parent, but also to the co-parent as well, because there are instances where it's not just the person who's giving birth that has postpartum depression, it can also impact their partner. But it did show a protective impact on their partner's mental health as well. The last little bit is then the interstitial spaces. So what I mean by that is there is, unfortunately, some issues in the community in terms of you have folks that are becoming parents and aren't able to find queer welcoming spaces in parent groups that are structured for cis het folks. And so they go to their queer spaces and they are told that they're not welcome there because they've chosen to be parents, because being parents is the heteronormative thing to do. So it's important to acknowledge the fact that just because you're part of a community and becoming a parent doesn't mean that your community is going to support you in that way. It's why it's a big thing with some prides that are like, hey, yes, we are family inclusive. We do want kids to come. Because there's some that just sort of don't even welcome the parents anymore as soon as they've become parents, based off of some of the folks that I know personally. So it's interesting to sort of see that there and how then we can work on that within our own community and go forward from there. And so that brings us to the hopefully fun bit of doing some case studies. And so I'm going to pause sharing for a second so that I can see everybody, so that I can have everybody kind of, I preemptively put together 1, 2, 3, 4, 5, 6, 7, 8, 9, put together groups, but then we might split them up a bit differently since Milton had to leave. So I know we don't have the same number, but okay. And then Elizabeth just jumped off. So we have, I guess, Nastasia, did you want to be in one of the groups, or do you want me to leave you out of the count of folks? I'm not sure if she's here. All right, so 1, 2, 3, 4, 5, 6. I'll do 3 groups then, since there's 3 folks, and I'm just gonna let it. Option. Let's do. another my. And what it's going to end up being is we've got about just over 30 minutes left. So it's really just kind of quick 3 to 5 minute presentations that folks will be putting together. I do. I'm going to move. And so room 1, I have as Liana and Louie. And so this is the case study for case study 1. There's also the link for the presentation slides. Room 2, in case Nastasia is still here, it would be Caroline, Tyler, and Nastasia. And let me do, so there's case study 2. And then for Jared and Joe, you'll have case study 3. And then I'll just share case study 4 when I get back to the slides. So I'm gonna go ahead and open all the rooms, and then I'll probably come, I know originally I said it would be like 30 minutes that we'll do a breakout room, but it's, if you can take the chance to read through the case study, do a little bit of research, we'll probably do slightly shorter version of stuff. So we'll say like 15, 20-ish minutes of researching around, and I'll pop through the rooms to see if that's enough time or if folks want a little bit more time. And then to just kind of put together a quick little summary about the case, and about there's questions that are in there already to sort of give you a guide of where to go with all the information. And then it's really just coming back, and I have a slide already with each of the case studies. So you're just reporting on your case study so that other folks get a little bit of an idea of what you found in that. So I'll go ahead and open the rooms, and then I'll jump around.
The way the law could be determined kind of like either it could be interpreted multiple directions depending, like we were saying earlier, kind of like on who the person you end up in front of is, like who that judge is that day. And so because there's multiple interpretations, there's not a clear or safe pathway. It's just, you know, you're kind of at the whim of the individuals participating in a system rather than having protections. So it's a little bit of a gamble.
Yeah, and it's interesting from the standpoint of, before I hand over to the next case study, if you do a quick search and just kind of look to see what the media narrative around stuff is, the law still reads like as husband and wife in Ohio in terms of adoption. So there's a legal standpoint for them to be able to say no. And there are Republicans who have been like, well, we don't need to change it because there's enough judges that sort of put it to the side kind of deal. So this weirdness of like not extending the protection of having the language change because it's already inclusive enough, because people are sort of just doing the interpretation route of things too. So being aware of what that means, even though technically federally in the states, anybody can adopt, right? So that's the whole overarching side of things. Okay, and then for Joe and Jared, did you end up going with 3 or 4?
We went 3.
Okay.
Yeah.
Cool.
So the summary of our cases, we have 2 cis gay men who are looking into using surrogacy to extend their family. They actually secure a surrogate in India and use a donor egg. The first pregnancy is lost, and then in between the first and second pregnancy, laws in India change, which require a medical visa for surrogacy, altruistic surrogacy, that is only extended to cisgendered heterosexual married couples. They then move to starting basically from scratch and initiating the process in Thailand, where they run into the same situation, a loss, and then initiation of a medical visa. So they're sort of left without the option to continue their family because of restrictions and different countries. So we were really sort of looking to see where surrogacy is illegal for gay couples or LGBT couples. And there aren't a lot of places. Actually, there's only 29 countries that recognize same-sex marriage, and of those, not all of them have explicit laws that allow surrogacy. Some of them, there's like an altruistic surrogacy route that you can go through with or without the need for a medical visa. Some of the countries in that do have explicit laws that do not allow surrogacy amongst same-sex couples or couples who are not married. So, but interestingly, we actually didn't find a lot of, I would say, legitimate websites that have information on where this is allowed.
Yeah, the information that we did find, Nepal and Russia used to be options, and they also passed laws banning LGBT adoptions. And then there was this article about the Israeli Supreme Court ruling that the parliament in Israel needs to pass a law allowing LGBT adoptions. And for those who are more versed in like the American legal system, like, yeah, if our Supreme Court makes a ruling, it's law, but like in other countries, their legislative body needs to craft something in response to the court decision. So it'll be interesting to see if Israel is another country that is safe for LGBT couples to adopt. But as of now, it looks like just America for paid surrogacy is really the only viable option for Vincent Julian. So
and then this is based off of an article where the Nevlin Peterson article that's part of the case study. It's based off of a couple where Klaus, and I can't remember, I think it's Peter and Klaus, where this is actually what happened to them, is that they were in India. They had found a surrogate. They had, she had gotten pregnant, lost the pregnancy, and shortly thereafter the laws changed. And they still have an embryo, at least at the time that the article was written, like 3-4 years ago, they still have an embryo that's been fertilized, that's stuck in India, that they can't access in any way because they can't get a visa to do that. And then the Thailand part of it too is part of their story. So it's very complicated bit of all it takes is the changing of one law. And there wasn't really time to touch on it as like a full thing, but there's also this change around adoption and stuff that's happened globally to where they will not, I think it might still be the case. When I wrote the chapter, it was the case, but it may have shifted where you can't adopt kids without any kind of disability from China as a queer couple, that you can only adopt children with disabilities in certain contexts. And so it's very kind of like, yeah, you can go into a whole discussion about eugenics and all this other stuff too, with like how, and necropolitics from the standpoint of like who's allowed to have a future, who's allowed to live, who's allowed to have personhood. How
I also think it's, oh, sorry, I didn't mean to interrupt you.
Oh no, you go ahead.
I was gonna say, I also think it's interesting that they have a fertilized embryo that is sort of stuck in India. And if they choose to not use surrogacy, that they still can't access that embryo because it seems like it's theirs, you know?
Yep.
I can see how they could say like, oh, you can't use surrogacy here, it needs to go somewhere else. And in my mind, they would be able to take that to another country or bring it back to the US. But I think it's interesting that their embryo is stuck there.
Yeah, but it's, I mean, that's that trickiness of borders. We don't think much of it because especially in the States, it's kind of like we're 50 independent countries right next to each other. But the one thing that we don't have is like as much of is issues crossing borders. Whereas as soon as you get then from like US to Canada or then in other contexts, like different international borders, then it starts to become a bit clearer how much those are reinforced and what that means. So I'm going to do the quick summary of case study 4 since we know we're technically over time. Folks are welcome to stay and chat about the trans inclusive versus exclusive after as well. But so for case study 4, this one was what happens pretty much, or the question that I had while writing this one was, what happens if you're a lesbian couple on paper who can kind of procreate without reproductive technologies at all at home? So it's Gloria and Julia are two friends that decided to have a kid together. Julia does have some gametes that she stored before transition just in case kind of deal. So did some sperm storage, but then also is trying to decide whether or not she needs to come off estrogen to see if they can try in another way as well. So they have tried a couple of cycles or a couple of rounds of the IUI at home, to where they've used the sperm that Julia had set aside to be able to try to conceive, but haven't had luck. So they've gone in clinic to see if they can get some help to do the IVF route instead, and are being told that the times that they've tried at home do not count towards what Gloria's insurance needs for her to be eligible to have the IVF covered because of being a lesbian couple. And so they go through the process of, and it's kind of a two-in-one from the standpoint of, they decide to go through the process of writing an appeal to the insurance company to explain circumstances to see if they can get coverage, and choose to sort of go through and try to find a clinic at the same time as doing this. And while they're waiting to find out about the appeal, they kind of hit another roadblock from the standpoint of every single clinic, and it's a common practice, requires you to screen in to be able to access different care. And so during the process of screening in, Julia notes in her appointment that she's finding it to be very stressful, that they've had to go through the appeal, that it's stressful, but it seems like it's worth it. However, the way that the person who's doing the screening has noted it in her chart is to say that she feels it's too stressful for this to be safe for them to do right now. And so the clinic that was their top choice tell them that they can't proceed until there's lower stress kind of deal. So like that misconstruing of things, the screen that can happen that on paper is meant to be kind of a protective thing, or making sure only safe parents are who become parents kind of deal, continues that pathologization. I always trip over that word, pathologization of folks that we're insisting doesn't happen since the change of the DSM, but still does because of this heavy focus on, well, where are these health disparities coming from, and people being trained to think that it's at the individual level problem versus the systemic sort of issues of inclusion and such, and it being to where it translates that stigma into notes that kind of causes additional barriers for people being able to access stuff. So sort of taking into consideration the complexity of everything. And I know we unfortunately missed a little bit of when I started the recording again, so I apologize that I missed Louie and Liana's stuff in there, but there will be kind of this bit. And if you want to, I'll give my 2 cents on the trans inclusive versus trans exclusive or specialty care, and then turn off the recording, and then we can kind of either scatter to the wind and come back at 2 on the main link, or kind of sit around and chat if you want to. So in terms of, well, does a single clinic need to make a point of being inclusive so that whoever walks through their door can have inclusive care? Or should we be doing these clinics that are specific to people? And I think the answer for both is yes, from the standpoint of, you don't want to have it be to where it takes a 2-hour bus ride for somebody to go get inclusive care because the clinic that's 2 doors down from where their apartment doesn't know how to properly intake them, right? So it's about shifting that narrative in terms of just having like name and partner versus name and like husband or that kind of deal, right? So like very specific framing and intake forms and other stuff, and making sure that we're thinking about the experience from even before getting in the door, and then what happens when you're with the people that are checking you in, when you're with people who are taking care of you, when you're sort of leaving, and who's following up with you as well. And it's just kind of, it's tricky from the health system standpoint of it being this kind of personalized care or individual care, and especially in the US, in a health system that doesn't really even finance itself to do the daily sort of things that need to happen. And so it's trying to figure out then how you can shift what's already happening to be, I was training a group of midwives here a couple weeks back and had somebody ask, well, what's the best thing to do? Like, how can you make sure that you're doing what you need to do for the patient? And it's really just knowing, or going through that process of knowing, to just ask the question of the patient of, what can I do for you? Versus having a whole protocol to guess before somebody comes in. So having it be welcoming, but then understanding that it's that discussion at that individual level as well when folks come in. So I'm going to go ahead